Welcome back to pharmacology, where we finish off looking at toxicology. We previously saw that a lot of toxicodynamic and toxicokinetic data needs to be reported in your assignment on your particular toxin. We also saw that by studying these toxicodynamic and toxicokinetic principles, you would revise some of the important aspects when studying drugs, pharmacology. Parameters such as clearance, volume of distribution, T1/2, use of dose-response curves, any important lifespan issues, the use of antidotes with substances that have a toxic profile where you have to do a risk assessment and then a management. To continue looking at these sorts of toxicodynamic and toxicokinetic investigations when looking at new drugs, or as we said, old drugs, just new indication. Even so, a new study on that old drug for this new indication might still require a randomized controlled clinical trial. You could still use a lot of the previous historical data, preclinical and other clinical studies on its safety profile, or in the case of, say, thalidomide, its post-marketing surveillance data to inform those ethics committee approvals, or to inform the Therapeutic Goods Administration when approving that substance for its new indication. And we indicated that the authority that has to take responsibility for having all of those levels of investigation, or that previous investigation data made available to committees within their organisation or to the Therapeutic Goods Administration, is known as the sponsor. We saw that the sponsor had to be an Australian entity. They are accountable under Australian law. They may need to do any clinical trial exemptions if you're applying for approval without a clinical trial but have alternative data, or perhaps one of these notification schemes so that adverse drug events and adverse drug responses as well as interactions can still be reported. We also saw that to avoid too many animals dying for the sake of human therapeutics, we can now start to do high throughput screening tests, computer simulations, applying knowledge to do a risk assessment on that new drug. We do pharmacokinetic studies, that was absorption, distribution, elimination, looking at what metabolic enzymes affect it, what its half-life is, volume of distribution, theoretical estimates, looking at its clearance from the body and measuring that rate of clearance, and knowing precisely what target. And if there are various different forms of that same protein target, then which particular one is the drug selective for. So all of that is applied in the risk assessment stages, plus that randomized controlled clinical trial data where we've actually tested the efficacy of that drug. And as we said, that has so many variables controlled, and right down to which people would be allowed into the study to investigate those likely hazards, that you can quite likely miss a lot of hazards. And so to get a full measure of effectiveness and, just monetary efficiency of that substance, you do need this post-marketing surveillance. You do need to then report back to the TGA any worrying signs, whereas we saw with celecoxib, it might not be removed from the market. It might just be put under a black box pending removing its approval. And so there were these stages of drug development that took many years for the pharmaceutical companies. And even in complementary medicine research, we're now still seeing long times to complete this important preclinical study data and the clinical studies on new complementary medicines. So a reasonable expectation then of recouping those research dollars once the drug is available for marketing. Also to keep in mind some of the very costly diseases that burden that they have on society and on our health budgets that this research is trying to target, and or perhaps looking at old remedies and new leads. So Alzheimer's disease is a good example here, where some other older drugs, acetylcholinesterase inhibitors, were perhaps revamped, but the lead was there to then study them in Alzheimer's disease, not with great results or data as yet. So other research areas are beginning. So looking at this tumour necrosis factor that we mentioned as being important in necrotic processes, inhibitors of this mediator are being investigated in treating Alzheimer's disease, but also drugs that target 5-hydroxytryptamine receptors and many other new ideas. But note 5-hydroxytryptamine there. That's one particular molecular mechanism that we'll see as a common target for some of these new drug leads. So we saw with that same receptor for 5-hydroxytryptamine, it might be drugs that are antagonistic at that receptor. We saw that with migraine prophylaxis, where the initial stages of all of the symptoms of migraine might be due to a constrictive effect when the person starts to get that aura or the wavy lines in their vision, and the prophylaxis will stop that vasoconstriction stage. That's the mechanism of action. So some examples were methysergide. It's a derivative of ergot, a particular natural alkaloid that has been known for thousands of years to have those observed effects. It came from a fungus that develops on rye. There's a herbal preparation from Tanacetum parthenium, feverfew, that similarly is preventative in migraines and works at the same molecular target as the pharmaceuticals. So stressing that the principles of the way herbs work is the same as the principles by which drugs work. Thalidomide we mentioned was one that was going to come up for old drug, new drug developments. It's now used as an immunomodulatory substance and in a rare cancer. But in all of these uses, it is still category X in pregnancy. That historical data remains. And so you have to know that your client would not become pregnant or is not pregnant before that therapy is started if that person was a female. And we're going to talk again about that bliss receptor that has been recently characterized and it appears to be so very important for explaining the mechanism by which Chinese medicine therapies work as well. So the natural substance was anandamide, and we have now characterized the various receptors, and we're looking for drugs like tetrahydrocannabinol that might be agonists at those receptors, but we've also looked at antagonists that might act as appetite control mechanisms. Some of these have been studied overseas but were never approved for registration here in Australia. But we also saw that cannabinoids could act synergistically with opiates and opioid substances, so that you could take the opiate or the opioid in much lower amounts and thereby suffer less adverse effects from it. So there was the different 5-hydroxytryptamine receptors that are targeted with different therapies and at different stages of development of a migraine. When you look at normal cerebral blood flow, it would be at a normal percentage. We've indicated it there at 100%. And so we're showing you there that you get a vasoconstriction very early in a migraine, where the person first of all might get symptoms of an aura, through to then the headache shown here in pink. So at levels where vasoconstriction has taken blood flow down to about 60 or 70%. But then in response perhaps to that initial vasoconstriction stage, there are changes that go on in the brain, and it's not just at 5-hydroxytryptamine receptors there are a whole range of other mediators, substance P and so on, where ultimately the response is a vasodilation, an excessive cerebral blood flow, as you can see there, up to about 140%, and it's at those stages that the person then develops the nausea, vomiting, that headache that you just want to die from. And so eventually those symptoms will abate, and of course for some people they do not. They can last for 24 and 48 hours, a variable pattern there with that cerebral blood flow. So because you get this two-stage pathogenesis to a migraine, there's two different types of treatment. There were those prophylactic ones that prevent the vasoconstriction, and then there were those that treat an acute attack by causing a vasoconstriction so as to overcome that vasodilation that is causing all of the excessive symptoms, vomiting, diarrhea, and so on. So there's some areas for new drug development. There are many, many, many biologically active peptides that are targets for new drug developments, more than we can hope to mention. But in later topics where we look at drugs acting in body systems, we're going to look at the endogenous opioids, the enkephalins and endorphins again. So ones where there is still just preclinical testing being done, drugs that might target bradykinin or cholecystokinin or neuropeptide Y. With bradykinin we're looking at mediating pain, so we're looking at pain relieving medications, and with CCK and neuropeptide Y, these regulate food intake and appetite, so we're looking at drugs that would help with treating obesity. But the other important one, where there's been some newly released drugs for post-marketing surveillance, drugs that target the endothelin receptors. Remember, endothelin affects levels of nitrogen monoxide production via this particular enzyme, nitrogen monoxide synthase. And so by finding antagonists to endothelin, you may be able to raise levels of nitrogen monoxide so it can produce its beneficial vasodilatory effects in various hypertension disorders or preeclampsia and so on. So another area for research that we've mentioned before, looking at not just enkephalins and endorphins and how to enhance the actions of drugs that work at those receptors using synergistic substances like THC, but actually exploring this cannabinoid receptor in more detail, and looking for other drugs that are agonistic or antagonistic there. Perhaps with tetrahydrocannabinol we may want to find better routes of administration than ones that could potentially affect the elasticity of your alveoli, so finding some other way other than inhaling it. When it comes to immune responses, they are very complex, and now there are a range of interleukins. We're going to ask you in your preview to concentrate on interleukin 1 and interleukin 2. So with interleukin 2, there's a new proposal for thalidomide. It actually targets interleukin 2. So this is the old drug, new indication, and approving it for treatment in TB. So once again, repeating that all of that historical data still has to be used then in its risk characterization and management. It would still be category X in pregnancy. So yeah, go back and review that co-stimulation idea. I used the analogy of 2 keys needed to unlock the vault in some workplaces. So here, 2 keys needed to unlock the T cell and activate it to become that helper T cell. Alright, some other ones that involve the immune responses. Because we now know what antibodies are, we are producing antibodies as drugs. These are synthetic, they are chimeric, they might be mixtures of a human and an animal antibody, or something that's been humanized so that there is less adverse reactions to it and so on. And so you can tell where it's at in the process of developing that antibody into a drug by the suffix that is used. Well, we won't go into it in too much detail. We'll just give one particular example. We have infliximab. The fact that it has MAB in its name tells you that it's one of these antibodies that's been made by an in vitro process. Monoclonal antibodies is what MAB stands for. And so this was a substance used in treating diseases affecting the immune system, but for other diseases it actually exacerbated symptoms, enhanced autoimmunity, so it's contraindicated in multiple sclerosis. This one, interleukin 1, it's a cytokine. You saw that it speaks between white blood cells, macrophages, neutrophils, and so on. So it's pro-inflammatory. And so we have this antagonist, anakinra, that blocks the effects of that mediator and reduces the inflammatory response. So anakinra is a DMARD, a disease-modifying anti-rheumatic drug. More on those DMARDs when we look at drugs affecting body defences, but we want you to early go back and review that interleukin 1 and its important role so that you can understand how it would work in rheumatoid arthritis. There are other drugs that are immunostimulants. Aldesleukin is one. It works simply because it's a recombinant DNA transcript from translation from a transcript, and this aldesleukin, synthetically made substance, enhances T cells, so stimulates an immune response. So this was important, we've seen clinically, in destroying some renal cell carcinomas. But this aldesleukin, because it has very few indications at this stage, it has not been adopted by a drug company, and so it's known as an orphan on the Therapeutic Goods Administration register. It hasn't been adopted yet. So there's other substances that are made by recombinant DNA technology. They may be made in yeast, where we have a transcript at an ATS ribosome, or we might take bacteria and use their ribosomes to translate transcripts from little segments of DNA that we have inserted into those bacteria. And so this is what's been done with human interferon, a whole range of those. Now, one of them, interferon beta, is the treatment that multiple sclerosis does respond to. It reduces a lot of those autoimmune aspects, even though multiple sclerosis is more and more coming out to perhaps be a lipid peroxidation damage, more similar to the way cholesterol damages the arteries, the way that multiple sclerosis damages the myelin in the brain. It's a lipid injury problem, but still those autoimmune aspects are important in its pathogenesis, and these drugs that target that autoimmune pathogenesis, very important in the future. And now one other one, we have glatiramer. It's a synthetic tetrapeptide, one just totally made in the laboratory, but it has some uses in multiple sclerosis, unusual drugs. So once again, we have to study them for their adverse drug reactions. We've seen that some drugs produce totally bizarre adverse reactions. They're termed type B, simply for the word bizarre. These are unpredictable, idiosyncratic, would occur by some unknown mechanism in people, perhaps due to their genetics. Sometimes we can pin it down to being a drug allergy or a hypersensitivity problem, where if it's an allergy, it's IgE involved. If it's a hypersensitivity, it's a T-cell mediated response. A lot of other drug reactions are pharmacodynamic. They're just an extension of the normal mechanism of action of that drug to just when it's been too augmented. So they're titled type A. So they're quite predictable, whereas type B bizarre were unpredictable. Type C adverse drug reactions are chronic. We've talked about some of those when we were talking about how there might be changes that go on in the kidney long term with use of lithium, let's say. And we also saw that development of drug tolerance and physical dependence comes under that category of a type C chronic effect, a changeover in receptors perhaps, or maybe not the receptor itself. If it's a G protein coupled receptor, it could be any of those integral or peripheral proteins that were involved in transmitting that cell signal. And delayed effects, there was a variety of these. We even counted carcinogenicity as being a delayed effect, because we saw that for something to transform a cell to being malignant was a very long and involved process, and there were many steps where the body's own immune surveillance could reverse and repair all of that damage. But how some of these drugs are able to then, even though it's a long-term chronic effect, it's a delayed response later on. And then with teratogenicity, it's delayed to the fetus at a particular stage of development, and we saw with some delayed effects they truly are delayed. They are delayed to the next generation. Then type E, end of use responses, stopping a drug where you then get a withdrawal. We often saw that that was a receptor response where there was changes in turnover or sensitization or desensitization of the receptors, making more of the receptor or less of the receptor, making more of its little peripheral proteins if it was a G protein coupled receptor, or producing less of those intermediate messages and signalers. And then last of all, type F was failure of a therapy, and our classic example there was how, due to a pharmacokinetic effect, St. John's wort leads to metabolism of oral contraceptive pills and a whole variety of other steroids, and thereby stops the action of that oral contraceptive pill, so the person becomes pregnant. There is a failure of that therapy. So there were many of these new drug leads. We've only given a sample and a summary to show you what body systems are being targeted, so that you can go and review those body systems. That's more important than studying those new drug leads. So some of the body systems that we suggested would be important for you to read up on. 5-hydroxytryptamine or serotonin. We saw that was the receptor whereby certain Schedule 9 substances have their actions, certain plants and other substances that have adverse effects have their actions, where some migraine preparations are going to have their mechanism of action. Because 5-hydroxytryptamine is also important for platelet function, there are some future studies there as well, and also 5-hydroxytryptamine involved in some of these appetite controls that are being looked into to study and hopefully reverse our obesity epidemic. We saw that we've asked you in the past to preview purines. So adenine and guanine are your purines. We're particularly looking there then though at adenine itself, or adenosine, or ATP as being used as drugs because they're neuromodulators. Prostaglandins might also be neuromodulatory, and we've mentioned prostaglandins a lot when we were talking about inflammation, so here's just another one of those proposed areas where there may be drugs investigated to change many neurological disease processes by targeting prostaglandins. So we said too many peptides that are mediated in the body. We identified endothelin as one particular one where we're looking at antagonists of that endothelin receptor so that we can raise nitrogen monoxide levels. There are other peptides that are being investigated for appetite control and so on. Nitric oxide has become very important in explaining the mechanism of action of many drugs, some used for treating pulmonary hypertension, preeclampsia and other disorders. We've asked you to review the actions of these cytokines, interleukin-1 and interleukin-2, so that you can understand some new drug leads into the future, interleukin-1 antagonists, interleukin-2 agonists, looking at interferon, another immune mediator. It's being used with some success in disorders such as multiple sclerosis, and some of these other immunomodulatory substances being used to treat rheumatoid arthritis. Thalidomide was our classic example of an old drug, new lead, being immunomodulatory and being used to treat rare cancers, but where its Category X data that came out of post-marketing surveillance back in the 60s is still used in its risk characterization.